agenda has been distributed to one and all. But what I recommend for one and all is to please kindly download our app AMC 2022 from the Google Play Store or the App Store, Apple App Store. And it's all lively being fed. The program, in case you miss, you have to attend anything, or as we are doctors, we might have emergencies at any point of time. You can see the live TV on the app. You can also see it on the AMC YouTube. You can see it on the Ortho TV, and it is also on the Facebook Live of Anup Institute of Orthopedic and Rehabilitation. So we have tried to reach all the places so that everybody can see, even if they can't come. So before I take you downstairs, I'll just go through the brief outline of the workshop basics, and then we'll go downstairs. Can we have the PowerPoint, please?
From start.
From start.
This one, I think, sir.
No, sir,
Hold on a second, sir. This one is yours?
Yes, sir.
Here it is, sir.
Yeah. So, now one thing, first I would like to make it clear. Now everybody, let's talk about knee. When we talk of I did a TKR, we all say that I did a Steiger TKR, I did a Zimmer TKR, I did a Merrill TKR or a Sharma TKR. But how many of us say that I have done a single radius knee or a multiple radii knee? So that's the concept which we should have. So when we are talking, we should have that what is the output? Are we doing a CR knee, cruciate retaining? In the same way, the robot. So I'm talking about the Mako robot, which you will be seeing downstairs. It is an enforced controlled robot. So it is an enforced controlled robot, because in the market you have other few systems and they are fully automated bird based robot. But the good thing about this is enforced control robot. Your hand will be guided where you have to cut. It is very fast, and you will see how it works here and in the live surgeries. Now, what we aim in arthroplasty is always accuracy, confidence and reproducibility, and a flexibility. Accuracy is the most important thing, because in the long run, if you are accurate, you can always say that the implant longevity would be 20 years, 15 years, as per the patient's activities and his status. Now, total hip replacement, a simple answer in degenerative diseases, and Mako is the next level. So Mako is an enforced controlled robot. Now, when we talk of conventional total hip knee replacements, the navigation was the first part when things were improved, and it was the first stage of advancement. Then that was the computer assisted total hip replacement, that is the latest advancement. And it is very important for all of us to adopt to the tradition, new tradition, because we should make sure that we use technology and be accurate. But it is very important to keep your old friends. Excuse me. I am saying keep your old friends, because old friends are gold, and this has been rightly said that those are silver but these are gold. So when everything fails in hip replacement, cemented THR is always helpful. In knee, you have to shift back to manual, and I'll show you in my cases tomorrow that how we jumble between technology. So in more than 300,000 surgeries are done, and it has dramatically reduced disability, and total hip and knee replacements allows the patient to start activities which they enjoy. We give them a pain-free life. And when we talk of modern joint replacement, we mobilize the patient in 4 to 6 hours. We have less pain during the surgeries, and patients go within 72 hours, maximum 5 days. As per their station, they do it. Obviously, automation and technology continues to be a boom, and we should understand where it can be helpful. So I would be focusing on total hip replacement. Tomorrow, Dr. Adarsh will focus on total knee replacements. So problems, dislocation, leg length discrepancy, impingement, early loosening, polythene wear, and all these leads to malposition. We all know about this. So when we talk of aims in arthroplasty, we talk about component fixation, bearing surfaces, leg length, offset, all these things. But if you analyze it in a much greater way, you will see that there are some surgeon choices and there are some things which you don't know. And the very best example is leg length discrepancy, which we actually cannot judge in lateral position. In supine da approach, it can be well judged. COR, we are not able to judge because none of us are planning here. So these are the things which we can improvise on. Of course, you can buy the best component, do anything, and the components will settle if you put it rightly. So complications where we can be better, as I mentioned, dislocation, leg length discrepancy, component fixation, and pain, impingement, bursitis, all these things. So computers and machines are more precise than human eyes. And yes, because we are in a robotic era. Now, what we can achieve, what we cannot. Leg length, yes, we can achieve with conventional, but more precisely in robotic, anti-version, retroversion, combined offset. We have so much insight over the theater that we are just right on target. Now let's talk of target, as I told you. Now this is one of the papers which shows that somehow when we are doing conventional hips, we are not within the Calaman and the Lunic safe zones. This is a paper published in JOA, and when we are with the robot, we are dead right on center where we plan. So to understand all this, we need to understand the workflow of THA. Now this lecture would help you when you go down to understand what I told you now, and again I'll be giving you answers what you need. So basically, when you'll go down, you'll see that you have the main design overview of the robotic platform. This is the machine which we use. This is the console which actually we can see on the right or the left hand side, depending on the side of the patient. And this is what the product specialist have. So we have two screens and one system. Now, how does it work? Now, I always explain to my juniors and my colleagues that in childhood, we used to play a small paper game. If you join 100 dots, you'll find a home. So we used to have it in the papers in Twinkle magazine, and every month we used to put 1, 2, 3, 4, and then you have a house or a boat. So first you have to give data to the computer. So that is known as registration. So registration is very important, and it is a common saying, garbage in is garbage out. If you don't register giving time, you will have a bad hip or knee replacement. Second is patient-specific planning, and the third is the bone preparation. So once we register the bone model, that is calculated in the accuracy level of 0.05 mm in the Mako system, and then the bone is prepared according to that. So let us say, for example, I'll show you in the live surgery or downstairs, we register the bone, and that is matched with the patient's own CT scan, and that has to be perfect in the range of 0.5 mm. So you cannot be wrong there. And then what you have planned, you take it from there. So we plan so many things. We plan and broach the femoral stem, combined version, intra-op cup planning, robotic cup placement. Now when we are doing a hip replacement, patient is in lateral, the patient is drooping forward, we don't know, the patient is obese, how much we are medializing, we don't have any clue. This is all planned. If you expose it well, the rimmer will go at once and just get your cups rimming exactly at the position where you want. And obviously the cup will get seated where it is rimmed. So we get all these values which I was showing you earlier on the screen. You can change it. Let us say you think you need a high offset. Okay, let us change from 127 degrees to 132 degrees. You see, okay, no, we'll increase the cup one size more. Okay, we'll lateralize the cup one size more. So I and we are talking in millimeters to give you a perfect joint so that you are absolutely pain-free both in hip and knee and unicompartmental. Another problem is that how much cut you should take. Now, over the time, what I have learned, one of my very senior professor, Jonathan Howell, he's the designer of Striker Triathlon. When I asked him this question, I think in 2009, he told me that you place your thumb over the lesser trochanter, and my thumb over the time has become exactly the size of what you need to cut. So he was joking, but we have a confusion how much you need to cut. So that actually you can template and plan, and nowadays you can do it on OrthoView templating softwares, but on this system we do it on a CT scan. So that's very good. Now cup positioning. You know that the cup has to be seated on the teardrop, but we can medialize 5 mm, 10 mm superior, inferior to the terms of 1 mm, 2 mm when we are doing a hip replacement. Calculate the anteversion and take it from there. We can see the cup placement on all the 3 sections of the CT scans, coronal, axial, sagittal, whatever you want, you can rotate it, do anything. So we'll shift down fast because you will be able to see how much we can get from the robot. I told you about a neck planning. You plan, then you have a magic knife, you take it there, you need to cut 20 mm and you will be there. So these are some things which we will see downstairs. Now, anything, I'll give you one basic example. Let us say you need to transmit something from Moria. So you need a satellite. So in here we say arrays, pelvic arrays, or in case of knee we have arrays that has got discs. So Visa disc basically they transmit signal from the body to the system. So you have the pelvic arrays. Checkpoints, there are 2 systems known as checkpoints. So these checkpoints are very important for the computer because the robot identified their checkpoint. If your patient droops anteriorly, the robotic arm droops anteriorly in hips and knees as well, which we will show you very well when we are doing stuff. Importantly, when we are doing a total hip replacement, especially, we are not sure about the position of the patient. Why? Because frankly speaking, we don't have the adequate lateral bolsters, because according to papers JBJS 2016, appropriate placement of the position needs 2 bolster, one at the ASIs on the same side and one at the pubic symphysis. Everybody, even best instruments, they have, you need to tell them, the table persons, the OT table persons which supply, that you need a bolster which is pelvic support and one going up. So when we talk about the OR layout, it's very simple. You'll see the gadgets not very big, but precision is 100%. So we place a pelvic array on the iliac crest, and then these are the satellites. What I'll say in layman terms, satellites. And then we routinely go what we want to do. These are the checkpoints which we have to put it in the acetabulum 1 and 1 in the femoral bone. These are for the computer locates that checkpoints, and it is beyond the scope why, how does it do, but it reads checkpoints. Now we take the leg length. So these checkpoints are landmarks which we take it, and then at the end of the day you can calculate the leg length, 1 mm long. Okay, we can increase the head size by, so it adjusts. We have so much options. And this is how we put the checkpoint on the acetabulum side. Neck cut, as I told you about the magic knife, we measure on the CT scan, the pre-op planning, and it is very well known that if you fail to plan, you are planning to fail. So we cut exactly as we want, and the magic knife takes us there. I'll show you something more when we are doing the live surgery. But the most important thing when you're doing a hip replacement is to have a good acetabulum exposure, 360 degrees. And for that, you need to have good retractors, proper instruments, and we'll take it from there. So once we expose the acetabulum, we have to register. As I told you, like in Tinkle comic time days, we used to put 1, 2, 3, 4. We have to landmark, identify landmark, and the landmarks are taken, accepted by the computer, and then it has to be turned to blue. That is a verification. That is you're in the range of 0.5 mm of accuracy. And then, as I told you about the femoral intraoperative planning, we also enhanced version. we also have control of the broaching angles, anti-version 5 degrees, 10 degrees, 15 degrees. So we calculate both cup anti-version, stem anti-version and combined anti-version, leg length, all is on the screen. You can mix and match, increase size, you know exact size of the stem. So this is how we do the registration. We take it from there, and then in the Mako system, that is the enforced control robot, we just do single rimming. That is, if the cup is 54, we'll directly go to 54, and one rimming, you are done. You'll stop where you have planned. If you have planned for 18 degrees of antiversion and 42 degrees of inclination, that's the final point, and we can verify it. But the point is, as Joseph Perry has told, and I elaborated in my slide, keep the old friends also. So we also have free rimming technique. Like we know how one rimming it goes, but it takes time to adjust. So we can do rimming in guidance of the computer. You can start from 42, 44, 46, and then gradually reach up to 54. Now, impaction. Impaction is also done by the computer, and it will tell you that it is 1 mm proud, 0.5 mm proud, and then 0 to 1 mm is acceptable as per the literature. Proudness of the cup, that is 1 mm I'm talking about. Now, we are on a big platform. So robot gives us visual feedback if you are going wrong. It gives us tactile feedback if you are going wrong. It gives us audible feedback we are going wrong. And last but not the least, yes, we kept inclination as 35 degrees and the verification it was 36. Version we planned 20, so we got 20. And I'm preparing a paper which shows how much it is variating from the CT scans post-op. So we cannot plan 36 degrees of inclination by normal eyes, that's clear. So this is how we take the check results and combined antiversion assessment. All these things compiled at one go. Stem preparation. When we talk of the stem preparation, we can pelvic arrays and know where the stem antiversion, how much you want, what is the range, and take it from there. All these needs initial femoral landmarks. I told you about the magic knife. We know the green and we have to take it there, and it will show that yes, it is 0, 0, and then you mark it with a cautery and cut it there. So we don't need to say to our future generation that our thumb is as good as the size of the cut from the lesser trochanter. And then obviously you have the appropriate exact plan of the stem. So roughly if the stem is 5, it can go to 6 or 4. But it will not be 2 or 3. So you will be knowing that yes, according to every calculation you are there. And we know about the broach stacking. These all must be looking complicated. But in couple of hours, I'll show you a live surgery, and we'll just go down and see how much we can understand all these things. Apart from that, in the software, we have the enhanced workflow and the version 4. Where we can flex, extend, see abduction, adduction, inclination and impingement. That is, you see the virtual range of motion before you start. And the best thing is that you can see the post-op X-ray before you even start the surgery. So roughly you know that your post-op X-ray would be like this. So this video is not working, but spinopelvic dysfunction. Before I end this talk, one thing I would like all of you to learn from my side, to get X-ray spine before you embark on a total hip replacement. There is a difference between all these things. Also, you need to know that what is the difference between navigation and robotics. Navigation will guide you, you will cut and then verify. Here, till navigation it is the same, but the robot will cut with your guidance. You cannot go wrong. So navigation was one generation earlier, but in my talk tomorrow, I'll show that in specific cases, you have specific things which is useful. Sometimes navigation is useful, sometimes this is useful. So coming to some results, as I told you, you are on target most of the times. So this target is within the target zone. Now, there are some studies about the antiversion. Yes, it is accuracy. Yes, accurate. It allows accurate reduction of the femoral native anatomy. And we are just resurfacing the acetabulum. We are not taking out more bones. It is just 0.5 mm. We are so particular in things. So things are getting better. We can plan so much on the robot. We'll all shift down and work on the robot so that we all should know, understand. Bone preservation. Bone cuts are so less in the robot that we are always there. The functional outcomes are definitely good. One of our papers is getting published, but believe me, patients are doing active SLR within 2 hours of the surgery, mobilizing within 4 hours, and as per our physiotherapist team, the pain scores are less and our definitely patients' outcomes are better. And these are some references what I talked about. So conclusion, I would say, why then we are still using traditional conventional techniques despite all the evidence? If you are a patient, what would you choose your surgeon to do? A 60 to 70% accuracy or 100% accuracy? And that's what we should think for the patient. Technology adaptation takes time. It took time for us all to adopt from manual transmission to automatic transmission, but I believe everybody now has got manual transmission cars and everybody is on touch screen telephones. So if you adopt, you'll adopt and take it from there. So another big question which comes, registration time. How much time extra you are doing on the registration time? So this is the average minutes of registration time. So actually, I'm sorry, but we complete our hips in about 35 minutes. So our registration time is not more than 5 to 6 minutes. But we plan more and take it from there. So change is the law of nature. It is already coming, already happening in some surgical procedures, telesurgery, and progress is inevitable. Technology is here to stay. Those who will perish, those who will stay will perish, and those who will not take it, they will retire actually. In cases of fused hip, the paper has been published, but in fused hip, it is of superb importance. I mean, the robot will just take you there where you want to be. So, patient mobilized 8 hours. This is the post-op X-ray, the post-op bony ankylosed fused hip X-ray. And I'm very proud to say that this is the first paper on the Mako 9 ankylosed fused hip, bony fused hip, published in Sicot Journal, which just published last month. So only the forms will change of the technology. The robot might become smaller over the day, it might become a chip, but we'll all be there. So without wasting much time, we'll shift down to the Sorbonne session or the Mako robot actual demonstration. I would like all of you to see, understand, and take it from there. I gave you a brief talk just to highlight what we'll talk down. But now I am not going to plan. It is you who will plan, and with the robot and the surgeon will execute. So learning points from my talk is that there are many forms of robot. The system which you are seeing is an enforced controlled robot. But tomorrow, one live surgery which is being relayed from Calcutta, it is a fully automated robot. So you'll see the difference. Now, navigation and this you have to understand. And third, that most important thing, definitely the world is shifting towards the robot. And then you'll have the masters, that is Frederick Picard, who is coming today evening and tomorrow. He's going to speak having a few lectures, who is the first person in the world in 1997 to do a computer-assisted orthopedic live surgery on a patient in France. So he is there with us over the 2 days. Probably he might have joined us as well. And we'll try to make this event very good. And with these few words, I'll end my talk. And I would like you to proceed to the Lumini Hall because the robot could not have been shifted. It is roughly 700 kilos. And so I have tried to set up things in the Lumini Hall to feel the robot and take it from there. Thank you. Any questions? So we'll shift down, sir.